Hello, everyone. We'll get started. Welcome to the Adult Obesity Guidelines webinar series hosted by the Office of Lifelong Learning and Obesity Canada. My name is Tanya Nagpal. I am a postdoctoral fellow at the University of Ottawa and with the Society of Obstetricians and Gynecologists of Canada. I'm also a volunteer with Obesity Canada, including vice chair of their Reproductive Years Science Committee. It was my great pleasure to be asked to moderate this session today. The new clinical practice guidelines are expansive. 19 chapters on a wide range of topics related to obesity diagnosis and management, weight bias, and more, all written by Canada's top researchers, health practitioners, and patient advisors. These guidelines are the first truly patient-centered clinical practice guidelines on obesity and the result of more than 2 years of hard work. Before we begin, I would like to acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. And now it is my pleasure to introduce you to our panelists. We are very pleased to have Drs. Kara Nerenberg, Elena Piccinini-Vallis, and Rhonda Bell to present on weight management over the reproductive years for adult women living with obesity. Dr. Rhonda Bell is a professor of human nutrition in the Department of Agriculture, Food, and Nutritional Sciences at the University of Alberta. She is also the WCHRI theme lead for pregnancy and healthy developmental trajectories. She has long-standing interests in how nutrition before, during, and after pregnancy impacts health and disease in women, their children, and across generations. She's a co-investigator in the Alberta Pregnancy Outcomes and Nutrition APRIN study, a longitudinal observational pregnancy cohort of approximately 2,200 women and their children. This is among the first Canadian studies to prospectively report on women's weight changes during and after pregnancy. Dr. Kara Nerenberg is an associate professor and clinician scientist at the University of Calgary, working in the areas of general internal medicine and obstetric medicine. Dr. Nerenberg's clinical and research interests focus on the prevention of cardiometabolic diseases, including obesity, in young women after common pregnancy complications, such as hypertensive disorders of pregnancy or gestational diabetes. Her research is supported by Heart and Strokes, CIHR's Women's Heart and Brain Health Mid-Career Research Chair. And finally, we have Dr. Elena Piccinini-Vallis. She is an associate professor and interim research director in family medicine at Dalhousie University and research lead in family medicine at the IWK Health Center. Her interdisciplinary clinical research, clinical work, and research interests focus on weight changes in pregnancy from various perspectives. She obtained a master's degree and her MD at Dalhousie University and a PhD in family medicine at Western University. Both Drs. Nerenberg and Piccinini-Vallis will be joining us as panelists at the end of the webinar to answer your questions.
Well, thank you, Tanya. It's a real pleasure to be here today to present this webinar on weight management over the reproductive years for adult women with obesity. I'm really pleased to be able to present this on the behalf of several of my colleagues who are not in attendance today. So Dr. Helena Piccinini-Vallis, Dr. Christy Adamo from Ottawa, Dr. Rhonda Bell, Dr. Leticia Pereira, and myself. Our objective for today's webinar is to review the evidence for management of weight during the reproductive years for adult women living with obesity. And for today's presentation, we have it divided over to 3 main phases over the reproductive years. These include the preconception period, during pregnancy, and postpartum. I'll begin with preconception. The preconception period is often thought to be one of the biggest windows of opportunity to make significant impacts on maternal, obstetrical, and fetal health outcomes by optimizing maternal health prior to pregnancy. It also gives an opportunity for healthcare providers and for women to discuss individualized health risks during their pregnancy and how they can make informed decisions about these risks and implement any interventions to lower these risks during pregnancy. There's a lot of epidemiologic data that shows for adult women with obesity that obesity itself is an independent determinant of several adverse clinical outcomes. As per our online guideline, these relate to infertility, gestational diabetes, and the hypertensive disorders of pregnancy. We also know women with obesity have higher risk of clots, depression, as well as cesarean delivery. We know that weight loss prior to pregnancy can improve some of these outcomes, but how is weight loss achieved? Several clinical strategies and resources are available to support women with weight maintenance preconception. This tends to center around combined behavioral interventions and pharmacotherapy when indicated. So, what is the evidence for combined behavioral health interventions? And by this, we mean nutrition and physical activity. There's actually not a lot of evidence out there, only about 2 randomized controlled trials, and both of these showed that women who were randomized to the intervention arm of these combined nutrition and physical activity interventions had significant reductions in their gestational weight gain once they became pregnant. And these one study included women preconception all the way up to 10 weeks prior to randomization. However, in general, there's not a lot of evidence. Some of the evidence found that not only was there less gestational weight gain, but that there was greater postpartum weight loss. And this is important too when we talk about a woman over her whole reproductive course, as that also has the opportunity to impact future pregnancies. At present, in terms of the evidence on pharmacotherapy, there's very little data to support clinicians and women in shared decision making. There's very little data to demonstrate what the fetal effects are of common pharmacological agents used for weight maintenance. As such, due to the limited safety data, it's generally not recommended that these agents be used during pregnancy. As such, through shared decision making with women, we generally recommend stopping these medications prior to pregnancy to limit accidental or unintentional exposure to the developing fetus in the first trimester. And now I'll pass over to Dr. Helena Piccinini-Vallis to discuss the antenatal or pregnancy section.
I'm Elena Piccinini-Vallis, and I'm going to review the management of weight during pregnancy for women with obesity. In the past, we didn't pay a whole lot of attention to gestational weight gain, but over the last 2 or 3 decades, there's been a pretty robust body of literature showing that there is a gestational weight gain range that's best for mothers and their babies. And there are guidelines for how much weight a woman should gain. This table shows the most recent guidelines for women with a singleton pregnancy and illustrates that it's not simply about one size fits all. In fact, the optimal range for each woman depends on her pre-pregnancy BMI. In the left-hand column are the 4 traditional BMI categories and the labels that we associate with those. The next 2 columns show the amount of weight that's recommended for each pre-pregnancy BMI category over the entire pregnancy. And then the last 2 columns on the right show the recommended weekly gains. And you can see that the higher the pre-pregnancy BMI, the less amount of weight a woman should ideally gain, which starts to become a little challenging for women in the higher BMI groups. And the truth of the matter is, most women do not gain weight appropriately, with approximately 60% of women gaining excess weight and approximately 15% of women gaining insufficient weight. Excess or insufficient gestational weight gain is known as guideline discordant gestational weight gain, and there are a number of adverse outcomes associated with guideline discordant gestational weight gain, as shown in this table. A number of factors influence gestational weight gain. Some of them are not modifiable, such as maternal age, parity, and ethnicity. And some of them are modifiable, such as healthcare provider advice and women's health behaviors, their expectations and knowledge, and their pre-pregnancy BMI. In fact, pre-pregnancy BMI in the obese range is itself an independent risk factor for guideline discordant gestational weight gain, especially excess gestational weight gain. But let's just step back for a moment and consider what happens in a typical healthy pregnancy, regardless of pre-pregnancy BMI. Basically, you get 8.5 kilos just for showing up. When you consider that the baby weighs approximately 3 kilograms at term, and then you add in the weight of the placenta, the amniotic fluid, the uterine muscle, and the increase in both the intravascular blood volume and in the total body water volume, there you have your 8.5 kilos. And this amount is just below the upper limit for optimal gestational weight gain for women with obesity. So it's no wonder that women with obesity have difficulty in attaining their target gestational weight gain. The strategies that we identified from the literature to help women with obesity to best approximate their target gestational weight gain are listed below. So nutrition counseling, physical activity, combined behavioral interventions, metformin, and healthcare provider behavior. I will address these very briefly one by one, starting with nutrition counseling. Nutrition counseling has been shown to potentially assist women with obesity in managing their gestational weight gain. For example, in a randomized controlled trial of 50 Caucasian women with obesity, the participants allocated to the intervention group had lower gestational weight gain than those allocated to the control group. In this specific study, the intervention consisted of 10 one-hour sessions with a trained dietitian, and the sessions focused on providing advice on eating a healthy diet according to Danish recommendations, and then they used food records and received individualized feedback for improvement. A number of studies have explored the role of physical activity in the management of gestational weight gain for women with obesity, and we have listed 3 studies here. In the daily RCT from 2017, which had 88 participants, women in the intervention group gained less weight than women in the control group. In the Barakat study published in 2016, which enrolled almost 800 women with obesity, 44% of women in the intervention group had excess gestational weight gain compared to 51.7% in the control group. And then finally, 348 women were enrolled in the Clayson study. And again, the women in the intervention group experienced lower gestational weight gain than the women in the control group. If physical activity and nutrition are individually beneficial, you would think that combining them would be even better. And in fact, a number of studies have shown that to be the case. We've listed some of those here, including the LIP study, the Therapeutic Lifestyle Changes Program, and the very large UK Pregnancy Better Eating and Activity Trial, also known as UPBEAT. In all of these studies, women randomized to combined behavioral intervention experienced significantly less weight gain than women in the control groups. Regarding the use of Metformin for managing gestational weight gain for women with obesity who do not have diabetes, a Cochrane review published in 2018 showed that although women receiving Metformin had slightly lower gestational weight gain, there was too much heterogeneity in the studies, and therefore this use of Metformin is not recommended at the present time. Healthcare provider behavior is an important area to consider, starting with something as simple as the provision of gestational weight gain advice. Although there are no data specifically for women with obesity, there is evidence that healthcare provider advice does influence the amount of weight that women gain in pregnancy. It potentially addresses a thought that women might have that if their healthcare provider didn't mention it, it must not be important. Well, here the opposite could be at play, namely that if their healthcare provider did mention it, then it must be important. But examining this area a bit more, we know that although healthcare providers usually weigh women during prenatal visits, only a minority actually discuss the weight results. Healthcare providers perceive a number of barriers to having discussions about gestational weight gain, not the least of which is that weight-related matters are perceived as being of a very sensitive nature, and it is easier to just avoid them sometimes. However, there is evidence that having a good relationship with patients and using a patient-centered approach to these sensitive conversations is quite helpful. And by a patient-centered approach, we're specifically referring to the patient-centered clinical method, which is a framework consisting of 4 constructs. Number 1, the clinician should explore the woman's experience of changes in weight during pregnancy. Number 2, the clinicians should try to understand the woman's proximal and distal context. And all that makes it easier for the clinician to find common ground on the best way to support women with obesity to best approximate their gestational weight gain targets. And all this really enhances the patient-clinician relationship, which then in turn makes it easier for the clinician to explore women's experiences of changes of weight in pregnancy, makes it easier for the clinician to understand the woman's proximal and distal context, and makes it easier to find common ground again on managing gestational weight gain. This framework was incorporated into the development of the 5 A's of healthy pregnancy weight gain, which also integrated behavior change theory, of course. I won't go into detail about this here, but for anyone interested, I would really encourage you to go to the Obesity Canada website for more information on this point-of-care tool for prenatal care providers. And then finally, the use of the electronic medical record has also been shown to potentially be beneficial to healthcare providers in their efforts to support pregnant women with obesity to best approximate their target gestational weight gain. And in a study by Nerenberg et al. Published in 2016, they explored the outcome of an intervention to improve healthcare provider behavior with the help of an EMR alert. They compared gestational weight gain among 333 women before the intervention and gestational weight gain among 268 women after the intervention, and found that the proportion of women who had weight gain within the guidelines rose from 28% to 35%.
Thank you, Helena. My name is Rhonda Bell, and now I'd like to move into discussing the postpartum period and what's known about the best way to care for women with obesity after delivery. The postpartum period is recognized to begin immediately following the birth of a baby, but its duration is not well defined. Many of the physiological changes that occur during pregnancy are resolved by about 6 weeks postpartum, but several physiological and psychological changes continue to exist for over a year postpartum, particularly if women continue to breastfeed. The period of 1 year is generally considered a working definition for the postpartum period. There's no established definition for excess postpartum weight retention, and there are many factors that affect weight retention during this period. This includes things like sleep patterns, psychological factors, and there are many maternal characteristics that are associated with weight retention, although clearly they may not be causal. Gestational weight gain in excess of the guidelines is recognized consistently as a risk factor for postpartum weight retention, though the evidence is mixed with regard to the association between pre-pregnancy weight and postpartum weight retention. For women who enter pregnancy with obesity, a postpartum weight loss of at least the amount gained during gestation is recommended to not increase their risk of adverse pregnancy outcomes in a future pregnancy. Limited weight loss after pregnancy is associated with an increased risk of moving into a higher BMI category, and this information, this data is very consistent across studies and worldwide. Retaining or gaining weight between pregnancies is also associated with adverse pregnancy outcomes in future pregnancies. Some of the adverse long-term outcomes of postpartum weight retention or weight gain are outlined here. So of course they include things like additional obesity, gestational diabetes in a future pregnancy, and hypertensive disorders in future pregnancies. Those are the ones that have been looked at most extensively. There is some suggestion that by reducing the BMI in the postpartum period by about 2 BMI units, there can be a reduction in the risk of gestational diabetes in future pregnancies. As noted before, there's no standard definition of what expected or ideal weight loss patterns are in the postpartum period. The dietary reference intakes, which is part of comes from the Institute of Medicine in the US, they describe a weight loss of approximately 0.8 kilos per month for the first 6 months postpartum when discussing caloric needs. This rate of weight loss is not specific for women with obesity. Those studies conducted with affluent, well-nourished women are consistent with these observations. Many women seek behavioral interventions and also wish to speak with their healthcare providers starting at about 4 to 6 weeks postpartum. The clinical strategies and resources available to achieve postpartum weight management are quite varied and so far quite limited, focusing primarily on behavioral interventions involving typically physical activity, nutritional interventions, combined with some kind of motivational interviewing or goal setting strategies. And I'm going to talk just briefly about those now. Studies that have used physical activity combined with motivational interviewing during pregnancy have been shown to be beneficial to women with obesity in managing their postpartum weight loss. This is an older study where this evidence comes from, and in this case, the study involved pregnant women who participated in a program to limit gestational weight gain. Women with obesity in the intervention group who gained less weight within what we would now consider within the current gestational weight gain guidelines. They also had significant lower body weight at 10 to 12 weeks postpartum, and they showed sustained weight loss 24 months after delivery compared to women in the control group during the same period. Comprehensive approaches targeting both nutrition and exercise have also been shown to be beneficial for women with obesity. And those, again, have been shown to be most effective when starting prior to delivery, so during pregnancy. In the study listed here, the intervention group lost more weight at 2 weeks postpartum, but the maternal health-related benefits for this intervention did not persist at 1 year postpartum, perhaps because the intervention itself stopped at delivery. There are a limited number of systematic reviews and meta-analysis to look at these effects of physical activity on weight loss in the postpartum period in women with overweight or obesity. And combining physical activity with clear targets and nutrition had the greatest impacts across all of the studies that were included. Breastfeeding is related to a wide range of positive maternal and infant health outcomes, although the impact on postpartum weight retention remains under study. Women with obesity often face challenges with breastfeeding and therefore may require individualized support that begins prior to delivery. A prospective cohort study of a large number of women postpartum showed that the median duration of exclusive and total breastfeeding was lower in the group with obesity, and that women living with obesity had an increased probability of introducing solids to their babies earlier. The safety of pharmacotherapy agents for weight maintenance has not been established during breastfeeding. Therefore, these agents are generally avoided.
Thank you, Rhonda. Now I'll summarize some of the gaps in the existing literature. A common theme throughout our presentation today is that there's very little data about interventions to improve outcomes. In particular, there's a paucity of data with respect to women with obesity, and particularly the different categories of obesity. Many of the studies pool women who were with overweight along with women with obesity, and therefore it's difficult to make some separations in terms of the impact on obstetrical and health-related outcomes. Preconception weight management. As I mentioned earlier, it's an important opportunity to improve outcomes, particularly for obstetrical outcome and fertility. But we need more data as clinicians on how do we actually implement these interventions on a day-to-day basis. We need to reach a broader range of women here in Canada and their healthcare providers. But what's also important for the clinicians is that we need better tools on effective counseling strategies to discuss pregnancy risks, and these should be following a patient-centered approach. Another important gap is the question about weight loss during pregnancy or even low gestational weight gain. You'll find that this is sometimes recommended to women with obesity. However, the actual safety and fetal impacts of weight loss are still relatively understudied, and this is an ongoing emerging area of research. The patient-provider relationship is critical for supporting women in their preventative health journeys. But what we need as clinicians is point-of-care tools that are developed on evidence-based principles of patient-centeredness. This is really important when we listen to the woman's voice and amplify it. This will help us inform strategies on how to manage gestational weight gain. Postpartum weight management is also an emerging and important area. However, there still isn't paucity of information to guide clinicians and women with lived experience, specifically on the optimal timing, rate, and amount of weight loss in the postpartum period. We know that this needs to be individualized for women with their different environments and social situations, and we need to do better to develop the research to support women in this area, particularly in terms of motivation and education, and also simple clinical resources that women can use. Key messages for healthcare professionals include the following. It's important to remember that these reproductive periods represent the continuum of weight management over several years in a woman's reproductive lifespan. This is an important opportunity because women are actually accessing the healthcare system, and we can layer in these preventative interventions and discussion. This can help empower women on their knowledge and self-efficacy and lead to important health behavior changes. It's also important to recognize that this clinical practice guideline from Obesity Canada truly centers on gestational weight gain, and therefore, for additional information relating to actual pregnancy or obstetric management and the medical comorbidities, as well as anesthetic management, we would refer you to the SOGC guideline for their detailed comprehensive recommendations in this regard. Key messages for women with obesity during the reproductive years. Our guideline identifies that this is an important period, and it's important that women feel comfortable to seek support and education from their healthcare providers on strategies that they can actually use on a day-to-day basis to improve their own health outcomes, as well as potentially for the outcomes of their children, both in the short and the long term. The messages are simple, but also challenging to achieve. We recommend entering pregnancy at a lower BMI if possible. We know that for every unit increase in body mass index, there's an increase in complications. So therefore, if we can support women in lowering their BMI, it may potentially improve their pregnancy outcomes. Once pregnant, we recommend targeting a weight gain of 5 to 9 kilograms throughout the whole of pregnancy. That's about 11 to 20 pounds. And we recognize that often this may be associated with a very small amount of maternal weight gain, as the majority of this is attributed to the baby, the placenta, and blood, etc. After pregnancy, we really reinforce to women that it's important to achieve at least their pre-pregnancy BMI, and if not, a slight reduction in weight within the year after delivery. The recommendations can be summarized and found online as well. So as a summary, relating to the weight management of women with obesity, that is body mass index greater than 30, and these guidelines are specific to a singleton pregnancy, so meaning one pregnancy, not twins or triplets, and really focusing on adults over 18 years of age who do not have pre-existing comorbidities of diabetes, and that's important. So again, the general advice is that we recommend that weight should be discussed by healthcare providers, and particularly a discussion about what are the weight targets for women with obesity. And that this is important that this be done in the preconception period, so women already have a good understanding of how much weight to gain during pregnancy, as well as the postpartum weight loss, focusing on about a 5 to 9 kilogram gain throughout the entire pregnancy and a weight reduction within the first year of pregnancy. How is this achieved? We recommend combined behavior change intervention that support both nutritional and physical activity. And at all stages, again, pre-pregnancy, during pregnancy, and post-delivery. Nutritional counseling alone can also be beneficial with regards to specific pregnancy nutritional related requirements. Physical activity alone is also recommended. At least 150 minutes of moderate to vigorous physical activity per week is important in achieving the gestational weight gain targets and also postpartum of weight maintenance targets as well. Pharmacotherapy in general should be individualized, but there's not enough safety data and therefore should be not used for the purposes of gestational weight gain. Studies so far only center around metformin, as the other agents are newer and less data. Breastfeeding, it's recommended that women with obesity be offered additional breastfeeding support due to decreased rates of initiation and continuation in this population for benefits to mom and to baby. The recommendations and full guideline can be found online at Obesity Canada. And with that, we will take any questions. Thank you.
Thank you so much to our panelists. I will now invite our panelists to please turn on their cameras. Wonderful, thank you. So this is turning it over to our attendees. If you have any questions, please feel free to pop them into the question and answer box right now. In the meantime, there was a question earlier, and I was wondering, Kara, if I can ask you to also answer it live. When do you recommend stopping medications? And I believe that would be in the preconception.
Yeah, so that's a really good question. And I'm glad someone asked that, because it's not a straightforward answer for what I put in the text box, but it's complicated because it depends on what's the indication for the agent. And so I assume in this case, we're talking about agents for weight management preconception. And there's very little data that we know about first trimester exposure, so we generally recommend stopping beforehand. We don't know optimal timing of when they should be stopped. If you wanted some information about the half-life of the drug or whatnot, there are a couple of resources that I generally recommend. So we used to have Mother Risk in Canada, and unfortunately that's no longer being updated and whatnot. So we often recommend looking at a couple online resources. One is called Reproductive, and it gives some good information about drugs during pregnancy. Another one I'll put in the chat box is free. Reproductive, you may have to pay unless your institution has a subscription, and that's through the National Institute of Health in the US. The other one is sorry, that's not through the NIH, sorry. The other one is BUMPS, or Best Use of Medications in Pregnancy, through the UK, that I'll put in the chat box, and then LactMed for breastfeeding. So again, it depends on the indication. We also have to recognize that some women with obesity may have impaired fertility, and it may take years for them to become pregnant as well. And so that's kind of where, through shared decision making, you can make the best decision about when to stop a specific agent. So I hope that helps answer the question.
Thank you so much, Kara. I don't see any questions yet in the chat, but I've got a few questions that I can ask just to get the ball rolling, and invite our attendees to type in any questions that they may have. Helena, I had a question for you. I was wondering if you could give us a bit of an overview on what we know so far in terms of weight loss before pregnancy, especially as a lot of guidelines in the past and even current guidelines have recommended weight management for women who have obesity before they're pregnant. So what do we know about that?
Yeah, thanks. That is actually a question that really interests me. So there hasn't been a lot of work on weight loss during pregnancy, and of course, the outcome being then weight gain in pregnancy. There are not a lot of studies that have been done, although I know a group that's undertaking now a very thorough systematic review. So that'll be very interesting to see when it comes out in publication. But one of the questions that we have about weight loss in pregnancy is how it actually happens. The weight loss before pregnancy is how it actually happens. Is it a gradual weight loss that isn't then associated with rebound? Because we know in the non-pregnant population that when people lose weight very quickly, often what we see then is a rebound weight gain, sometimes in excess of what the original weight had been. So if that's the type of weight loss that occurs before pregnancy, can we expect then that there will be a rebound weight gain, let's say? So women during pregnancy would gain more weight than they would have had they not lost that weight quickly before pregnancy. So is it a quick weight loss, or is it a gradual weight loss, which is tends to be less associated with rebound weight gain? And then can we expect to see that women would gain weight maybe more appropriately to their pre-pregnancy BMI? So that's a question that's out there, and we don't know a whole lot about it yet. What's causing this, when women lose weight quickly, what actually causes the rebound gestational weight gain? Does it have anything to do with appetite hormones? That's an area that I'm actually particularly interested in.
Thank you. And a follow-up question to that, we saw in Dr. Bell's talk for the postpartum period, one of the recommendations is for women to at least try to lose the weight that they gained during pregnancy. Is there any research or anything that you might be able to share in terms of if they were to be pregnant again, so in that inter-pregnancy period, is it possible to lose weight too quickly if you're pregnant too quickly in between that time period? And as well, when should women start really focusing on that weight loss in the postpartum, given that they just had a baby?
I'm actually not terribly well versed in the postpartum period. I wonder if Kara would be better suited to answer that. Not to put you on the spot, Kara.
Sure.
But I do know that interpregnancy weight change is something that's also important to recognize and look at. Yeah.
Yeah, no, great start there. I think that a lot of this data comes from observational data, and some of it's coming from some US administrative data sets. But there's a few out there that have demonstrated that if a woman does lower her BMI, I think, as Rhonda said, by about 1 or 2 units, even, that actually that is associated with each unit decrease in BMI is associated with reductions in some future pregnancy adverse outcomes like hypertensive disorders of pregnancy or preeclampsia, as well as gestational diabetes. So yeah, we certainly do recommend. Now, there's not great randomized controlled trials randomizing women to different weight loss regimens and then the impact on the next pregnancy. So as I said, it's all through administrative data that we're looking at this. I think your second part of your question is like, what's the right timing? I think the answer to that, we don't know optimally and biologically, and whether, some of the hormones that persist postpartum and through breastfeeding, how they actually impact weight loss. But I think the answer to that question, I'll just be really simple as a clinician, is just anytime, and probably like the earlier the better from, health behavior habits. I think Rhonda Bell, who's not on this call right now, actually, there's someone in the audience who's probably more expert on this, who just finished her PhD, Dr. Leticia Pereira. So I don't know if you're in the chat box, if you wanted to answer that or put in a smarter comment than us, but certainly I think like the simple answer to that would probably be, it's a longitudinal process and starting early with the health behaviors in the early postpartum period so that they're adapted. Now, that doesn't really take into consideration some of the physiology there though as well.
Thank you. And yes, if anybody would like to add any comments as well, please do so in the Q&A or the chat. We have a question from Barbara. Thank you, Barbara, for your question. Metformin is often used in infertility. Once pregnant, should it be stopped in women who have obesity and have become pregnant? You said it's not helpful for weight management in pregnancy specifically. So Kara, I think this might be a question for you.
Oh, sure. Yeah. So for weight, so that's a really good question. So metformin, to help women become pregnant, there's thoughts that it will help regulate ovulation and improve fertility. So, if the indication for metformin was fertility, then, we'd recommend it's no longer needed. If the indication was for weight management, again, we would recommend not to be on that agent for weight management purposes. We now know from some of the gestational diabetes work that from the MIGHTY trial and whatnot, there's still a little bit of controversy about first trimester metformin exposure, even in the diabetes literature. Certainly second and third trimester, it's been used for glycemic control for diabetes and for gestational diabetes as well. So I think going back, if the indication was for women with obesity from ovulation and fertility, once she's pregnant, I would discontinue it.
Thank you. Lena, did you have anything to add?
No, not to that question. Sorry, I was going to suggest something that if nobody asks, I would like to talk about.
Yes, please.
Okay, so that is about healthcare provider behavior. For example, a question that comes up periodically is, what about routine weighing? Does that make any difference to gestational weight gain? So we prenatal care providers usually weigh women at every prenatal visit. I know there are some people who don't do that, but certainly in family medicine, that's very routine for us. And has it been shown to make any difference to gestational weight gain? There are a couple of studies I know that were published in 2016, I think Brownfoot and another one by McCarthy, that didn't show, that showed that there was no difference between groups that were weighed routinely and those that were not. But what's not clear, and I think this is the critical piece, is what happened after the weight was checked. So was nothing said, or, which I know wasn't the case in those two studies, but was it just a matter of the provider saying, this is how much weight you've gained, or was it did the provider say, this is how much weight you've gained and it's outside your, either below or within or above your target? or did the provider actually engage in something called that behavior change psychologists would call counseling? So did the provider try to understand the woman's experience and her context? It's so critical to understand context. Family, cultural beliefs, family beliefs really shape a woman's own beliefs about health in pregnancy, because women want nothing more than to have a healthy baby and a healthy pregnancy. And if her belief is that gaining weight is really, it doesn't matter as long as you're gaining lots of weight, it's a healthy baby, the clinician has to address that head on, but has to elicit that information from the patient. So just providing advice, and that's what's not clear in studies, what exactly happened? Did the provider actually engage in a patient-centered conversation about the weight gain, or was it simply a matter of providing advice? And that's going to make all the difference. So that work needs to happen, that really sort of informed by behavior change theory. And I think we'll start to get some answers about provider advice once those types of studies are undertaken.
Thank you so much, Elena. And I'd like to ask a follow-up question to what you've just said before I address the next question. You mentioned that healthcare providers need to elicit this information from their women. Do you have any advice on how to bring up the sensitive conversation of gestational weight gain with their pregnant patients?
Yeah, so I alluded to the 5 A's of healthy pregnancy weight gain in the prenatal section of this presentation. And as I said, that's a tool that's based on both behavior change theory and patient-centeredness. And the first A is actually to ask, and it's to ask permission to have a conversation about weight. That really, the basis for that ask piece is because it tends to level out the power difference that tends to exist between providers and patients. So like it or not, in most scenarios, in most clinical scenarios, the provider is the person who has all the knowledge and the patient is the help seeker. And so there is inherently in that a power differential. And by asking permission to engage in a conversation that is sensitive, you balance it out a little bit more. So that's how I would suggest starting those kinds of conversations. And that's what we've suggested with that tool.
Thank you so much. And Dr. Nerenberg has actually linked the 5 A's tool in the chat for everyone as well. So thank you. The next question we have in our chat from Ryan, either one of our panelists can take this one on. What recommendations do you have on the use of commercial meal replacement products and programs such as OptiFast during any of the 3 time periods that you discussed?
I can speak to the prenatal period. So I guess the question is with the goal to lose weight or with the goal to just manage weight gain within targets? I guess either way, I don't know that there's much literature out there on that at all. So I would think for now, I wouldn't, but I'm kind of stumbling here a little bit because I don't, yeah, go ahead, Kara.
I would echo that, Ryan. I think it's a good question. I think when we did our systematic review, I think you'd be quite shocked at the paucity of evidence there. And so, you know, there's very little about even just simple health behavior change. So, and we didn't come across anything about commercial meal replacement. So again, that was in our lit search, but, you know, potentially that might be an evolving area.
Awesome, thank you so much. So another question I guess I can ask is, you talked a little bit about this, Kara, about there isn't really the best time yet known for when we can offer women that preconception counseling. In the interim, though, as the data is evolving and the research is evolving, do you have any recommendations for engaging women in weight management questions in the preconception period?
Yeah, I think that there's a whole opportunity for improvement here. We did a review of Calgary's preconception clinic over about a 2 to 3 year period. And again, specialist clinicians, all internists, counseling women on, a wide variety of preconception health topics: hypertension, substance use, etc., kidney disease, clots. And what we actually found from doing a retrospective study was that about 43% of the women in clinic, their BMI was classified in the obese range. And in fact, our group really did not recommend our group, as far as we could tell from the chart documentation, there was no discussion about preconception weight loss, or even a simple discussion about what their weight goal target would be during pregnancy. I think Rhonda's research during pregnancy showed that women had no idea they were only allowed to, or not allowed, but recommended to gain 11 to 20 pounds. So we've actually used that to change our consult service, to change that preconception visit to actually, we have some posters up on the wall for healthy pregnancy, but we also now did try to standardize the preconception consult, where there was a brief mention about, again, I'm not sure that everyone does it the same way that Helena suggested, following the 5 A's of obesity approach, but generally we try to have in that conversation that given your BMI, that these are the increased risks of a high BMI with pregnancy, such as gestational diabetes, cesarean delivery, preeclampsia, etc. And during that is when we start talking about that, healthy suggestions for weight maintenance and supporting women. The challenge as clinicians then is that we don't have a lot of resources to direct women to. So we've tried to engage systematically about how can we refer women then. Like it's as Helena says, it's not great just having a short conversation if you have nowhere to direct women. So we've tried to engage a little bit at a system level of how can we support women, and I think we dropped the ball there. And again, I feel that there's a lot of stress for women planning a pregnancy, and that this is one added thing that, I think we probably need a bit more research in there for very simple evidence-based tools that clinicians can use that actually promote a positive discussion, as opposed to this risk-based approach. So I'm not sure if that helps you, Tanya, but even in our specialist clinic, we were ineffective in discussing weight maintenance, preconception, and we had nowhere to send patients. So I think we're doing the same as everyone else. Yeah.
Thank you so much, Kara. We have a question here from Barbara. What about women in their late 30s who are anxious to get pregnant, have obesity, and have little motivation to lose weight?
Yeah.
Either one of you.
I can. Yeah, Barbara, I think we see that a lot. So again, in our preconception clinic, we see women, who might have multiple medical comorbidities, obesity, hypertension, etc. And again, we always say, like, there's no perfect time. This is a recommendation. These are some simple strategies, but we recognize that it's not something that would delay their pregnancy. So they certainly don't have to achieve. Having said that, though, sometimes the fertility clinics do have some restrictions on the patients if they may need IVF and whatnot procedurally. So again, that may also sometimes be where the next conversation comes up. The fertility clinics sometimes recommend weight management as well. And I know that there's some studies ongoing in that area. So it's certainly not something that they need to delay their pregnancy, especially with, more advanced maternal age. But again, it's that conversation of risks of, this does mean that your pregnancy, you're more likely to need more testing, more ultrasounds, et cetera. So sometimes that little bit of information can also be important for an informed pregnancy.
Perfect, thank you. I guess I have a question for either one of our panelists. In regards to some of the data, I can't remember if it was in Helena or Rhonda's section of the presentations. There was some research showing that women who have a nutrition and exercise program during their pregnancy, they see benefits for postpartum weight retention as well. Do you have any thoughts on, is that a result of the appropriate gestational weight gain that they may have experienced, or potentially maintaining behaviors or adopting behaviors in the postpartum? Just sort of curious more so about the postpartum period, where the recommendation now is to lose weight, especially the weight that you have gained during your pregnancy.
Well, I mean, I would suspect that, having, if the combined behavioral therapy has translated into less gestational weight gain, then of course it's easier to, you don't have as much to lose postpartum. But I don't know any studies to back this up, but I do know that if healthy behaviors are incorporated into one's daily routine and become normal for a person, then you would expect that to continue postpartum as well.
And a quick follow-up question to that, Elena. What are your thoughts on, we see studies that synthesize data for prevention of excessive gestational weight gain and then less gestational weight gain or reduced gestational weight gain? And how should we interpret this data?
Oh, that's a really good question. Yeah. So oftentimes, because people are trying to distinguish between excess and adequate. I mean, the studies look at the three groups: so insufficient, adequate, or excess. And the focus, the majority of the literature is now separating between excess and not excess. So I think the focus at the moment has been excess gestational weight gain. Yeah, I'm not sure if that answers your question.
It answers my question. I know it's difficult to sort of, with some studies looking at reduced gestational weight gain, and then it begs the question of clinical significance of the amount reduced. So yeah, there's a lot of work to be done, I think, is the takeaway.
There is a lot of work. I mean, in the past, we really were very concerned with insufficient weight gain. That was really the focus. Nobody really paid much attention to weight gain if it was sufficient. And really, it's with the change in demographics of women entering pregnancy and their older age, the focus has started to shift, and now we worry more about excess weight gain in pregnancy, because that's really where as I said earlier, 60% of women, in some studies as high as 70% in some countries, 70% of pregnant women gain excess weight, and only a minority gain insufficient weight. So the focus has really shifted over to excess weight. But what is clinically significant? I would treat weight gain as a categorical variable. I think that makes it a lot easier to interpret results. When you say that the change in weight gain has been by a kilogram, yeah, clinically, is that really significant or not? So I think interpreting weight gain as a categorical variable in reference to the weight gain guidelines makes it a little bit easier.
Thank you. Kara, did you have anything to add?
No, not to that one.
Yeah. And so I'm just keeping an eye on time, and I don't see any other questions in the chat, but I'd love to open it up to our panelists if you have anything else you'd like to add.
I think the only thing that I would add is just, your team's doing a lot about the patient experience side, and I think that's really important. So throughout this whole conversation, we really need to take into consideration the patient perspective in discussing weight and pregnancy. It's a tough topic, and we don't want to add to any weight shaming or stigma generation. The only thing I did want to add was that the concept of weight loss, we don't know enough yet about weight loss during pregnancy and whether we should be recommending it. So just, I think some women get messaging from, other sources that women with obesity should be losing weight. And again, we don't recommend that they lose weight during pregnancy yet. Certainly there's not any evidence for that yet from whether that is, if it does have any benefits for mom or harms to baby. So yeah, just keeping in mind the women that we're all treating and not recommending for weight loss at the present time.
Thank you, Kara. All right, and on that note, I'll bring us to our finish. Thank you once again to our panelists, as well as to Dr. Rhonda Bell, who participated in our webinar. To our participants, thank you so much for joining us. We would really appreciate your feedback. So as you'll see on your screen, there is a link and a QR code. We ask that you please take a few minutes following this webinar to complete our evaluation form. You can use your camera to scan the QR code, or the link has been posted into our chat box as well. Once again, thank you so much. And this recording will be available for purchase. The slides are not going to be available, but the recording will be later on. So thank you, everyone, and hope you have a wonderful day.